Okay, our next session, we're going to have three speakers. They're going to speak up to about 10 minutes each, and then we're going to have them join together with other speakers on a panel for a follow-up discussion, kind of what we did yesterday with the industry panel. And so our first speaker today in the clinician panel is Dr. James Ecklund, the medical director and chair of Inova Neurosciences and the Spine Institute, and he chairs the Inova Fairfax Hospital Department of Neuroscience. He previously was chair of neurosurgery at the National Capital Consortium that included Walter Reed Hospital, the National Naval Medical Center, and the Uniformed Services University. Dr. Ecklund is a retired colonel, served as a neurosurgeon in Iraq and Afghanistan, and is particularly interested in neurotrauma, including injuries such as blast injuries. So, Jim, welcome.
All right, well, thanks, Mike. And congratulations to Mike and Tor and Hal and everyone on this wonderful meeting. I appreciate the invitation. And I'm going to briefly talk today about why we do all this great research. In this new era of precision medicine, what do our patients really want and expect of us? So let's start by just reviewing a case. This is a 50-year-old woman who I saw a little while ago. She presented with loss of taste and smell. She's married with 2 kids. She's the vice president of a large company and very highly functional person. And she presented with this lesion, which is, frankly, an olfactory groove meningioma. It starts invading the anterior skull. So we did an operation on her, a bifrontal craniotomy. Went beautiful. No brain retraction, put a lumbar drain in, positioned her, the brain kind of fell away. We had access to the tumor, we took it out, rebuilt her frontal fossa. And post-op, films looked great. She, on the surface, looked wonderful. But as she got back to work, she was having trouble. She had some subtle personality issues. She had some difficulty with higher cognitive functions, functioning at her level. So on one end, we think, oh, the outcome's fabulous. On the other hand, on the other end, it took her 4 months to become fully functional at the time of her job. So whether we're talking about a brain tumor, a stroke, an aneurysm, spinal cord injury, neurodegenerative disease, we always got to remember there's patients, people behind these diseases. People with dreams, with desires, with aspirations, with expectations. And unfortunately, the diseases, the injuries, and sometimes our therapies cause neurological impairment. And in addition to the emotional burden that this creates, there's also a huge financial burden to society, not just in the care we give them, but also in the lost productivity that comes when we don't get these folks back to where they need to be to function. So what do we consider a good outcome? As clinicians, as researchers, it depends. It might be they're alive. It might be, they're back to work. Could be their imaging looks great, and Lord knows we've got hundreds of thousands of people with great looking spine images that are still disabled by back pain. We can make the spine aligned, but that cord injury still causes horrible dysfunction. We can open up the anterior cerebral artery with interventional techniques, but if we don't do it timely enough, we're left with a patient that really is devastated in many ways. But even if we can't repair their biological problem, they still want to be able to be functional. They want to run with the president. They want to talk to the kids. They want to work and think very efficiently on the job. So today, we often measure outcomes. That didn't work right. There we go. Maybe I double-clicked it. So today, we often measure outcomes basically by subjectively in a quick clinic visit. The patient's doing well, and the husband will sit and tell you, oh, I'm doing great, I'm doing fine. The wife's behind him, if she's there, saying, no, he's not, doc, he's not right. I mean, I can tell you. But we don't really dive into how are the patients really doing oftentimes. But we'll look at their films, and we'll look at those type of things. So at the end of the day, what do our patients really want? They just want to get better. They want to feel good. They want to function normally. And get back to life. So when we look at these folks and try to determine how they're really doing from a functional standpoint, when we do have the time and we have and we're compulsive enough to actually do formal functional assessments, we'll use some of these scales, the Glasgow Outcome Scale, the Glasgow Outcome Extended Scale, a number of other things. But these are really still weak in psychosocial metrics. So tomorrow, we're going to have much more robust scales. NIH and Walter's group have already given us and are working on several NeuroQual and NIH Toolbox common data elements. We're also going to be layering in genomic data and personalization in that way. And this requires, as Walter said, big data analysis, new tools. And social media will eventually be rolled in here. Right now, the industry can tell you what their companies are going to buy, what they're going to purchase based on social tweets and what the society is going to do. We can tell how countries often are going to vote or directions they're going to take based on this analysis. We need to also apply that to medicine. So there are several common data elements already developed by Neuro. The problem is they're very complex, and data entry is really very time-consuming, too time-consuming. TBI, for example, has over 150 instruments in that database, in that common data element set alone. And there's also a heterogeneity of the disease, which makes the analysis even more complex. So therefore, our data entry must really integrate into our normal patient care workflow by working with the electronic medical records that are so widely used and figuring out ways to actually extract that data in a way and analyze that data in a way that's meaningful. So when people are afflicted with neurological impairment, what we do today is we do standard PT, we do standard OT, we do speech therapy, and this takes time. And we tell the patient, you know what, it's just going to take you time to get better, but we're going to do the best we can. But what we probably need to be doing is more focused, personalized therapy that's tailored to that patient with true neuro PT, true neuro OT, focused cognitive rehabilitation if we can figure out what is right for that particular patient, which is a challenge in and of itself. And really focus on performance enhancement across all domains. Now this already exists in some places where we're looking at diseases and disease-specific rehabilitation. But in the future, it's going to be more demanded by our patients. They're going to expect to be personalized in this area of precision medicine. So at all of our institutions, we've got multiple programs, and these are just 4 of ours. And the thing about these programs is they have similarities in the support structure and the infrastructure they need to really work to optimize the patient's outcome. So what we're really working toward is to take our clinical neuroscience programs and to layer them with a support infrastructure that truly has expertise that's focused on the neurologically compromised patient, navigate those patients through this complex array, support by the whole process by an integrated analytics team so we can collect the data, analyze the data, and both inform our research and inform better practices, and then envelop all that by research efforts to include clinical trials, focused on clinical outcomes, device innovations, and translational research. So traditionally in neuroscience research, we were focused on disease. We'd strive to understand mechanisms, whether it's macro, a big mass that causing the brain, take it out, will they get better, to microscopic, well, how can we affect some of the cellular processes? And we'd evaluate our intervention, often use surrogate measures because our functional measurements were so gross, some of these single things wouldn't actually show a change on the outcome of the patient, but the outcome might be a Glasgow Outcome Scale, which as opposed to more specific how they're functioning at higher cognitive levels. And when individual interventions didn't work, we transitioned to now let's try multiple interventions, hit that cellular mechanism at multiple levels and see if that doesn't work. And that was all good ideas. But in the future, we're going to need to be focused not just on the disease, but on that disease in the specific patient. That includes striving to understand the genetic and epigenetic role, to provide more sophisticated functional outcome measurements, as we talked about, and then to better understand and intervene when appropriate for brain health and function. You've all been to the doctor, you get your physical exams, you get a bunch of lab tests. The lab tests that are done and the risk factors that he talks to you about, or he or she, and identifies, are really based on the Framingham data collection set back in the 40s and 50s, of which over 3,000 publications have been written on. And it's well studied, and we practice medicine that way. Have you ever had a brain H&P? There's really not a Framingham study for the brain. So this is our challenge, to understand what is brain health, how do we encourage brain health as we move forward. We also, there's the Exos, I don't know how many of you heard of Exos, that's an athlete performance center, and its main operations in Phoenix. 52% of the first round NFL draft choices went through Exos. And they went through that to improve and enhance their physical performance. Why don't we have an Exos for the brain? Especially as many of us in this room are aging and we want to be performing at top levels. There's also going to be more focus on functional restoration instead of just biological repair of our tissues. So we're going to collaborate with bioengineers, create exoskeletons to help improve function, to create robotic devices, and actually integrate them with the brain-computer interface. And I see there's a talk later in the day about that, and to help us control those devices more effectively and efficiently. And this slide's from my good friend Jeff Ling, who started the robotic program at DARPA. But basically, there's a race, I think, between our ability to better repair our intrinsic nerves, our intrinsic physiologic tissues, with bioengineering and advanced computing, so that we can create human-assisted neural devices to bypass these broken circuits, whether they're sensory prostheses, like cochlear implants, retinal things that we already have, motor prostheses, or cognitive prostheses, which are being worked on. And finally, why is this also important? Why is this focus on function so important? Well, when you think about it, it took 66 years from the time the Wright brothers flew this first plane at Kitty Hawk to the time we put a man on the moon. That's one lifetime. With the advances and the information age today and the communication and conferences like this going on, that progress is going to be enhanced rapidly. So I'd say that our grandkids today are going to easily live to over 100 years old. On the other hand, their neurologic system may not survive. So do we want them to just be decayed and not thinking and not able to function, or do we want them to be robust and active and healthy? And that's our collective challenge, because at the end of the day, the patients just want to be well. So thanks very much.